Oops, I lost my home. Who is saying? This is intraocular lens. The home of the intraocular lens is the capsular bag. When they are not there, they are malpositioned. Unplanned cataract surgery, which is not well handled intraoperatively, results in unforeseen, unexpected, unpleasant results and with many surprises. They can cause malposition of IOLs. They are decentration, subluxation of IOL, pupillary capture, dislocation of IOL, and they can cause symptoms like blurring of vision, halos, recurrent inflammation, sometimes diplopia, and even glare. They can cause sight-threatening complications like decompensation of cornea, glaucoma, vitreous hemorrhage, and retinal detachment. Approach to manage such patient is individualized according to need of patient and position of IOL and also associated complications. Management can be of two types, with removal of IOL and replacing with new one, or without removal or replacement. As in this case, one haptic is in the bag, another one is in the sulcus, which can be rotated and reposited back with the help of Sinskey hook. IOL got his home. Sometimes we may see synechias. They bring out IOL from their home. Pupillary capture. This can be separated with the help of iris repositor. While releasing synechia, care is taken not to damage the posterior capsule or iris. With careful releasing, we can get round circular pupil. But there are certain situations where existing IOL is not able to reposit it back into the bag or near bag. So they need to removed and replaced with the new one. In this case, posterior chamber IOL was in the anterior chamber. So this PMMA lens was removed after making scleral tunnel. This PMMA lens was causing corneal decompensation. There was another situation where iris claw IOL was hanging. One haptic was placed and another was loose. So attached haptic was removed. As there was no support of the posterior capsule, pupil was updrawn. It was replaced with the anterior chamber IOL. This was quite interesting case where there was fibrosed capsule, subluxation of the fibrosed capsule along with the IOL. While removing the IOL, this subluxated fibrosed capsule started coming out. So it was reposited back and tried to open the capsule but failed. So decision was taken to remove this fibrosed capsule. See the dense synechia. After removing the capsule, anterior vitrectomy is done to create a space between the iris and the vitreous. And in this created space, retrofixation IOL was tucked from behind, and IOL got his home back, at least near to the home. In trauma, one can get aniridia, aphakia, and one's dislocation of lens. This was a case. There was aphakia, aniridia, and total hyphema. IOL was dislocated subconjunctivally. So this hyphema was removed with the help of vitrectomy, anterior vitrectomy. Then scleral sutures were passed, and these sutures were tied with the NRadic IOL, and this IOL could be placed near their home. This was 12 years old boy, post-traumatic cataract, operated somewhere and got both the haptics in front, total posterior synechia. Inferior haptic was difficult to remove, so it was cut and IOL was removed. Total posterior synechia, very difficult to separate with the iris repositor. So these synechias were cut along with the posterior capsule. And then iris repositor was placed between the capsule and the iris, and they were actually cut, and space is created between the iris and the posterior capsule. Another new IOL was implanted in the sulcus, but while doing this, pupil was distorted. So pupillary reconstruction was done with 10-0 Prolin suture by slip knot technique. Round circular pupil could be achieved. IOL could be placed near its home. So with certain modification, learning different techniques, one can place IOL again in the bag, at their home or near the home. So earlier management not only easier to treat but also prevent complications. So right choice at the right time gives ultimately wow results. Thank you.